Take two. All right, welcome everybody. We're going to talk about congestive heart failure today. My name is Max Bulgren, and we're going to get into it here. What is congestive heart failure? Does anybody know?
Helicopter.
Helicopters, not quite, but we'll figure it out together, okay? Heart failure, we're going to talk about the anatomy of the heart for a minute and what we're looking at when we talk about just heart failure. These are fragile cardiac patients that led to heart failure, usually due to some sort of MI, cabbage, right? You know, these patients often come out of the hospital after having major cardiac events, or it could just be hereditary. Long-term blood pressure issues, diabetes can lead people to fall into heart failure as well. Most commonly, we're going to see people with left-sided heart failure, and that's what we think of as EMS, in the emergency setting, right? These patients have fluid backing up into their lungs, right? Severe dyspnea, trouble breathing when they're walking. These kind of things are the things that we're common to seeing, right? When I lay down at night to sleep, I can't breathe, blah, blah, blah. Or we can have right-sided heart failure. And right-sided heart failure, essentially for us, we're looking at excessive edema in the abdomen or the legs, or even in the arms. So commonly we'll see it in the lower legs, ankles, feet. Most people who go into heart failure are going to start with left-sided heart failure and progress to right-sided heart failure or total heart failure. Some people can present with only right-sided heart failure. These instances are rare and are often due just to like myocardial infarction that presented just on the right side of the heart. All right, let's talk about some signs and symptoms. But before we do, we can take a look at these two hearts here as example. Right here on the left is a normal heart, and on the right is an enlarged heart from a congestive heart failure patient. And you can see how much larger and how much different the anatomy looks, right? There's a lot more fat, there's a lot more muscle mass, and with the muscle mass, there's thickening of the ventricular walls and that muscle. But let's talk about our signs and symptoms here. What are we going to see in these patients when we get there, right? We're going to see edema on our physical assessment. We're going to notice dyspnea, or they're going to report on our physical assessment. We're going to note JVD in the neck, especially when they're hypertensive. They're going to be hypoxic when we check their vital signs, right? They're going to have an unknown cough a lot of times. Orthopnea is a very common finding, which is just, you know, they're short of breath and they're lying down flat. And then dyspnea on exertion. We all have hypotension here as well because we could have shock in these patients, especially in the later stages of congestive heart failure. These people have very weakened, fragile cardiac states. Their ejection fractions are low and could lead to cardiogenic shock very easily. So you'll see them hypoxic, hypotensive, and their heart rates could be low if they're on a bunch of beta blockers, and it could be screaming high. But we need to make sure we're supporting these people and recognize that they're in some form of heart failure and we're not overwhelming them with fluids. We're addressing their oxygen needs, we're addressing their hypotension and their shock with pressors. All right, let's talk about our assessment findings for a second. We're going to start with everybody with a good sample history, right? People may not know that they have congestive heart failure, but they may be on diuretics, which would be a good indicator for us that they do have congestive heart failure. As long as you know other things like your blood pressure medicines, your beta blockers, your calcium channel blockers, and those are often common medications they give people who have congestive heart failure to help their heart work better and put less stress on it, control the rate, to make it easier to try and get their ejection fraction up. What's your work of breathing, right? Are we talking in word by word? Are we speaking in full sentences? We get to their lung sounds. Are they wet, moist, right? Do we hear rales? Do we hear cardiac wheezing? Those would be indicators that we have fluid overload. How is their position? Are they tripoded? Are they sitting up? Are they talking to you, laying down? You know, these could be indicators, especially in severe dyspnea patients, that they're slipping towards an impending respiratory failure, right? That they're really anxious and they're tripoded. You know, we can listen to heart tones, and then we want to talk to them about excessive weight gain. Have they noticed in the last 2-3 days, week, that they've had a large increase in weight? We're not talking a pound or two, we're talking 20, 25 pounds in these patients. Is not unheard of, but if they do report that, they should be weighing themselves every day, that they had a 25-pound weight increase over the last week. We should be very suspicious that they have fluid overload in their lungs. It's going to need immediate treatment. And then we need to talk about edema as well, right? And we're going to find that in the feet and legs. And over here on the next slide, you can see we have a little Scale of the edema, grades 1 through 4. So you can see here, measured in millimeters, but it's essentially just how far down you can press your thumb into the foot or the ankle, the lower leg, wherever the edema is most prevalent. We want to make sure we're pushing down all the way until we meet resistance, and we want to be looking for pitting, which just means the skin's not returning or bouncing back to its normal position easily. These are signs of congestive heart failure. In people with really severe edema, you may also see weeping or fluid running out of the legs. Let's talk about some vital signs we're going to see. Look for these patients, right? We're concerned about their respiratory status. We're concerned about their heart status. So we're going to be looking at their EKGs, their heart rates, look at their respiratory rates, right? What's their work of breathing like? Are they breathing 60 times a minute? Or are they breathing 10 times a minute? We also want to consider their ventilatory status, right? Are they perfusing oxygen, right? What's their end tidal look like? What's our SpO2 look like? What do we want those to look like in these patients, right? We want the SpO2 to be above 90, right? Normal, especially if they're on supplemental oxygen. We want to try and maintain above 94 though for these patients to make sure that we're recruiting all the alveoli that we can. End tidal, what should we expect to see there? It's very easily could be low because we're not going to be exchanging, right, gases in the lungs. Checking a sugar, and then again the weight. We want to make sure we're asking about their weight, if they have any weight gain. Let's talk about some treatments for these patients and what we're going to do for them. So here you can see we have some examples of people who might be in a tripod position, sitting or standing, right? We want to make sure we're putting them in a position of comfort. They're going to want to be erect, seated up. So it's not uncommon for them to be, need to be placed in a seated position where they're elongating their torsos and being able to open their lungs up. So they need to sit on the stretcher and they need to have their feet off of it for a little bit while you get the treatments going and get them comfortable. That is very reasonable, these patients. They're going to be anxious. They're going to feel like they need a pace around. So let's talk about their oxygen now. We want to make sure we're ensuring an oxygen of greater than 94% on these patients. We can obviously start with the cannula breather in our lesser patients, but in the acute emergent setting of congestive heart failure, we're going to be going right to probably CPAP for a lot of these patients. You may hear audible gurgling, right? Obviously, you're going to note rails on your assessment. You may have a lot of decreased diminished lung sounds on these patients. They're not going to be taking in good, full breaths, right? They're going to have pretty poor end tidal, pretty poor chest rise and fall. You're not going to notice that they're taking in good, full breaths. So CPAP is going to be really important to help give them that increased pressure into their lungs, help recruit alveoli, and help push out the fluid from their lung tissue. And then obviously, if they can't maintain or support CPAP, we always go to bag valve masks. We make sure our bag valve masks have PEEP on them now, that we're maintaining a good PEEP on these patients, and we're gently ventilating them, right? We want to be recruiting alveoli and helping to push fluid out. We don't want to be overloading the lungs and overventilating them. All right, let's talk about CPAP. This is going to be the big one that we're going to cover, right? We're putting these people on CPAP. We want to make sure we're starting at 5 and titrating up to 10. For our maximum, we want to, worry about all the things we worry about with CPAP, right? Do they have blood? We're going to cause them to have tension pneumothorax, blah, blah, blah. Are all factors here, so I start small and we're going to increase. But these patients are, for our protocol, right, as we talked about, they're going to present with severe dyspnea. They're going to be unable to maintain oxygen greater than 94%. They're going to be hypoxic. They're going to look like garbage. They're just not going to be doing good. They're going to have accessory muscle use or chest retractions. And obviously we can use this for CHF or COPD. And the big one here is impending respiratory failure for the use of CPAP in these patients. And our CHF patients are going to be falling into this category when we're going to CPAP of impending respiratory failure. Our contraindications, first one being hypotension. We want to be monitoring these patients' blood pressures. We worry about hypotension, especially if they start off hypertensive. In case we have a tension pneumothorax, it's going to lead for them to be hypotensive. So we want to be monitoring that. We may be giving them nitrates that are going to help lower their blood pressure as well, or even a Lasix, right? That could lower their blood pressure on top of it. Are they able to control their secretions? If they're not, they cannot be on CPAP, right? If they have excessive salivation, if they are vomiting, We don't want to be blowing that back into their lungs. This is going to lead to pneumonia and further respiratory failure and arrest. Decreased mental status. If they're not able to maintain their airway because their mental status is dropping, we want to be taking these people off of CPAP and going to a BVM with an adjunct, or you're considering RSI. And then obviously if their anatomy doesn't tolerate the mask, they can't be on CPAP. Let's talk about our pharmacology. For these patients, we are going to start with the most common one we're going to be giving them. If they have just heart failure, right? They're going to be hypertensive. We're going to be getting fluid out of the lungs and into the peripheral vascular system. So we're going to start with nitrates, nitroglycerin, right? 0.4 milligrams sublingual every 5 minutes is needed, or 1 gram nitro paste on the upper chest. We'll be watching the blood pressure and maintaining it greater than 100%. 100 systolic. If these patients are anxious, like we talked about before, right? You're putting them on CPAP, they're hypoxic, they can't breathe, they're feeling anxious, they're feeling overwhelmed, overcome by the situation. They may not want CPAP, they may not be able to tolerate it. So we have the option to give them lorazepam in our protocol, 1 to 2 milligrams IV for anxiety. And don't be afraid to give it, right? These patients need this positive pressure from the CPAP. They need this treatment, so we need to make sure they're staying on it. And then if we have extended transport times greater than 30 minutes, we can consider giving them Lasix, okay? Does anybody have any questions today? No? All right, great. Thank you, everybody. Have a good day.